Good morning, everyone, and thank you all for tuning in to Plugged In, where we address basic fundamental tips in orthopedics through different lecture-like talks and series, while also addressing different common knowledge gaps and deficiencies that we do have. So before we begin, I do want to send a huge thank you to everyone who's been supporting us thus far through either the Instagram or the podcast. Thank you all so very much for your support. And of course, thank you for your continued support. So today we do want to take a 360 and do things different and address things from the educational side. So I'm sure we all know that there's going to come a point in time, whether it's OAs, sub-Is, electives, anytime at one point when they put an image on the screen and they turn to us with the abundance of student know that we have and ask us to interpret it, read it, or tell us what's going on. I personally am not a friend of images. I do not know what's going on. And most of the time it is like a lucky guess. But throughout this series, we do want to address that and help us all kind of progress towards being better at either reading, interpreting, or not looking so clueless when it does come to images. So with that, my name is Henson Destiny, fourth-year medical student at the University of Miami Miller School of Medicine. And today we have with us Dr. Onor, who's going to be helping us out by kicking off this series for us. I'm going to let him introduce himself. And of course, as we go through this, we're going to try to make this as interactive as possible. But if you would, Gabe.
Absolutely. So my name is Gabriel Onor, go by Gabe. I'm a second-year resident at Thomas Jefferson in Philadelphia, and I did medical school at Brown. Unfortunately, I didn't have the pleasure of doing sub-Is due to the COVID year, but I certainly am very familiar with the fact that, as Henson mentioned, we frequently turn to medical students and say, hey, read that x-ray. So happy to be here today, and I would just like to go through a case with you guys today.
All right. Perfect. All right, then we can pretty much get started with this. And I think Gabe is going to be going over tibial fractures today, which definitely high yield pathologies, and that's definitely what we want to focus on.
Yeah, so with this one fracture, or with this one image rather, we might turn to the medical student and say, hey, what is this? So it's important to kind of get your bearings, know, first of all, what bone am I looking at, and what's going on the screen. So kind of can take like a 30,000 foot view, take a step back, stall a little bit by using this kind of standard sequence of words. So you start out by saying, so this is an AP and lateral of, and then you figure out which bone it is, of the distal fibula and tibia in a skeletally mature individual. So by the time that you've said all those words, you can kind of stall because that's kind of the standard sequence of words that you're going to use while you figure out what's going on the screen. All right. So you can say, so this is a AP and lateral of the right distal tibia and fibula in a skeletally mature individual, demonstrating a spiral distal third fracture of the distal tibia. So as I mentioned, I kind of use the words distal. So it does include more proximally than just the distal third in the x-rays, but notably doesn't include the entirety of the fibula or the tibia. So moving forward, based on what I just said, you kind of want to get images of the entire bone. Anytime there's any abnormality on an x-ray, you want to visualize the joint above and the joint below, as we frequently say. And if you don't, then you would have not visualized that there also on this image is an AP and lateral of the knee, demonstrating an oblique fracture of the proximal fibular shaft. So as I mentioned again, anytime you get imaging, you see a fracture, make sure you have imaging of the joint above, joint below. Just get the entire bone in question. So you're in the call room. They call you on the phone. They say, hey, in the ED, we have a 30-year-old or so with a tibia fracture. And at that point, my mind is, we've already seen the x-rays, but in my mind, if I haven't seen the x-rays, they say 30-year-old with the tibia fracture. That doesn't necessarily clue me into anything, because in my mind, I'm thinking, okay, what part of the tibia? Could be a plateau, could be a shaft, as in this case, or it could be one might call an ankle fracture, a tibia fracture. So tibia fracture doesn't necessarily clue you in. So you can ask, okay, hey, what part of the tibia, or you can just take a look at the x-ray. So the first thing I do whenever I get a call from the ED, I just say, hey, what's the patient's name? So as they're telling me about the patient, I can just look at the x-rays and kind of come to my own conclusions rather than having my conclusions kind of be drawn by somebody else. In addition to that, obviously on the x-ray, you're not really going to be able to definitively tell whether something's opened versus closed. So I would always just ask on the phone as well, hey, is this thing open, closed? And that kind of puts your mind as towards kind of what's the urgency of this. Additionally, because this is a shaft fracture, you're not necessarily worried about whether something is dislocated or not. But if this were around the joint, let's say this were an ankle fracture, if the ankle were dislocated, that kind of speeds you up, because this is something I need to get to this kind of right now, rather than taking care of this other task before I go there. Just due to the potential injury to cartilage, as well as the subsequent increase in rates and arthritis. So with anything dislocated, you want to get to that a little bit quicker. So you get the call about the distal third tibial shaft fracture, and immediately know you have to immobilize it. So you go down to the bay, you put your splint on, just so you can make the patient more comfortable, but also immobilize it so there's no further movement of the fracture fragments, particularly with the distal third. Even though it is distal, for the sake of control of the fragments, you want to put on a long leg splint rather than a short leg splint. So one going up above the knee to control for rotation, because a short leg splint wouldn't necessarily control for rotation, and there could be further movement of the two fragments. And this is kind of potentially more useful in the days in which patients would not proceed to the operating room with shaft fractures. Oftentimes these, in the past, many years ago, could have been treated non-operatively. And so if this were to be treated non-operatively, definitely it would need a long-term long leg rather than a short leg. But in these days, we pretty much always treat these operatively if the patient is able to go to the operating room. But definitely we'll need a long leg splint rather than a short leg. So first things first, you get it immobilized, and then one important feature of distal third tibial shaft fractures, you'll see it on ortho bullets a lot, and this is frequently a PIMP question, is the fact that they're very often associated with posterior malleolus fractures. And it's often subtle, and you can't necessarily always see it on x-ray of the ankle, because most of the time they're very non-displaced. They can be subclinical or so small that we wouldn't necessarily do anything about the posterior malleolus fracture, but very classically, distal third tibial shaft fractures are associated with posterior malleolus fractures. So given that, we get our post-splint X-rays. Just to, anytime you put on a splint, really you want to get imaging afterwards, and then we get a CT. And the CT is specifically a CT of the ankle. So you don't need a CT of the entire tibia, because we can easily characterize what the tibial shaft fracture looks like on X-ray. The thing we're more concerned with is a CT of the affected ankle. So as we mentioned, the posterior malleolus piece, that'll be more easily identified on CT. So you can see this sometimes on the sagittal cuts of the CT ankle, but particularly I find it's often easiest to just look at the axial cuts in order to identify if there is indeed a posterior malleolus piece. So this is anterior up here, we got lateral on this side. We know that because of the fibula being on this side, and this is posterior. So when I recorded it earlier, I kind of traced out the posterior malleolus piece, but you can see here this non-displaced posterior malleolus fracture in association with the more proximal, or with the distal third tibial shaft fracture.
Okay.
So with a patient with a shaft fracture, we often, or probably 99.9% of the time, treat this, if the patient's going to the operating room, with an intramedullary nail. The reason we would get the CT is to identify, hey, are we going to put a screw into the posterior malleolus? And that, for many surgeons, often affects the post-operative weight-bearing recommendations. In the absence of a posterior malleolus fracture, with an intramedullary nail treatment for the tibial shaft, many surgeons would immediately allow this patient to bear weight on the operative extremity. However, post-operatively, there's kind of controversy based on who you talk to in terms of, hey, do you let your patients bear weight on the operative leg if there's an associated posterior malleolus piece? And that can change, whether it's fixed or not. Some surgeons, even if they, put a screw in the posterior malleolus, wouldn't allow the patient to bear weight for 6 to 8 weeks on it while that fracture fragment heals. So ultimately, this patient proceeded to the operating room for intramedullary nail fixation of the distal third tibial shaft fracture. And as you can see here, we really want to get the fracture fragments to key in, and because with the fracture, the displacing forces are going to cause the fragments to malrotate, and so that's why you can often see dramatic pictures, clinical pictures of where you're kind of getting an AP of the patient's knee while you're getting a lateral of the patient's ankle, just due to the rotation of the fracture fragments. So in the operating room, you really want to pull traction and kind of get the distal and the proximal pieces to key in from a rotation standpoint, and make sure you have the correct rotational alignment while the nail is passing through. And because of how distal the fracture of the tibial shaft is, the entry point of the nail doesn't necessarily affect it. If let's say this fracture were more proximal, you would definitely be thinking more about using a suprapatellar approach so that you could get or entry site so that you could more adequately capture the site of the fracture. However, because of the distal nature of this distal third fracture, you're not necessarily worried more so about that. Wherever your entry site is, the nail will be able to adequately allow for reduction and maintenance of that reduction.
Okay. Actually, thank you. That makes so much more sense when it comes down to it. So when it comes to these, if you were to be asked, let's say you were asked, okay, there's a tibial shaft fracture. The first thing we wanna, and they say, what imaging would you get? Would you always say AP and lateral, or is there different? When it comes to X-ray, they're like, okay, what would you do first? Would you say you would get an AP and lateral X-ray of the tibial and then also the joint above and below? Or are there other views or imaging techniques that we would want to talk about?
Yeah, so with tibial shaft fracture, I think to start out, let's say if you're just getting a call from the ED, or your attendant is asking you, hey, you got a call, they said there's a tibial shaft fracture, what do you want to do? What imaging do you want? First of all, you want to start out with an AP and lateral of the entire tibia and fibula. Okay. So that you can visualize, hey, are there any other fractures? You want the entire, oftentimes on the entire tibia fibula films, you can get them to include the knee and the ankle. So you wouldn't necessarily need a dedicated knee or a dedicated ankle, but you just want to make sure that you're adequately visualizing the entirety of the bone. One thing I didn't necessarily mention, I'll go back to sharing my screen. As you can see here, it's kind of cut off, but we didn't address the fibula in the operating room. Many times that's the fracture of the fibula is kind of subclinical, just due to the fact that the tibia itself is going to contribute mostly to weight bearing postoperatively, and even in a patient like this where you don't go ahead and fix the fibula, you can still, the patient can still bear weight postoperatively. This, if you can imagine the mechanism, I didn't even mention the mechanism that this patient had, but just looking at the initial x-rays, it can kind of clue you into, hey, how did this happen? So you have a spiral fracture. The most likely mechanism is going to be a twisting mechanism. And you can imagine how that would then lead to this fracture up above in the proximal fibula, with the big sheet between the fibula and the tibia, the interosseous membrane. The twisting energy comes up, causes this fracture in the distal third of the tibial shaft, and then travels up through the interosseous membrane and exits at the proximal fibula. So it's one twisting mechanism, one energy or one event that caused both of the fractures, and that energy travels through the sheet.
Okay. Makes a lot of sense. Now, are most of these x-rays going to come with the like the directional, whether it's like a R or L?
They should typically label them, but it's often obviously sometimes they're not labeled. You can generally say, hey, the fibula is lateral, so this is probably right versus left. But who knows if the image is flipped right? But there's really no way to definitively tell. Particularly, you see a lot of X-rays of the hand. It's like, oh, the radius is over here, ulna is over here, but there's really no way to know definitively, like if you get an X-ray of the wrist, what side it is, unless it's labeled.
Okay. That makes sense. So when you're reporting images or you're interpreting the stall point, so you first say like the view, because you first mentioned that, okay, this is an AP and lateral. So you mention what view it is or like how the X-ray was taken. Then obviously laterality of the right and the bone that you're looking at. And then you say like the pathology that you're seeing in that case.
Correct.
Tibial shaft. And then afterwards, first thing you're gonna do, you're gonna immobilize it, you said, with a long leg splint. And then after you mobilize it, you will get a CT to look for the posterior malleolus, because that's like a high yield, like associated pathology. And that's better seen, you said, through axial CTs.
So it's better visualized with CT period. I usually, you're either going to see it on the sagittal or on the axial cuts. I think often if you use the axial cuts, it'll and scroll down to the plafond, it'll be easiest if you look at the axials. But you can see it on sagittal too, but it's difficult to see it on the sagittal sometimes if it's a small piece and or it's not really displaced. So I think best bet is to just kind of just scroll through the axials first and then look at the sagittals too.
Okay, yeah, that makes a lot of sense. And then from there, next steps would be, or obviously for an intramedullary nail. And you mentioned that as far as like the screw for like, if there is like a displaced posterior malleolus, that's like sometimes some surgeons, well, if they don't do it, they can go back to like full weight bearing. But if they do it, you said some surgeons allow you to put weight on it and some don't based on their own preference. Do they always put a screw, or is there, when it comes to their malleolus?
No, so there's not always a screw. There's not always a screw put in. As you see in this one, we didn't put a screw in. Sometimes the posterior malleolus is too small to the point where the screw that we would use is bigger than the fragment itself, so it wouldn't necessarily capture it too well. So if it's a very small piece, you can just leave it alone. But a larger piece, and especially if it's displaced, you really want to at least put a screw into it.
Okay. Yeah, that makes a lot of sense. And then follow up for this, they would just come to clinic afterwards and however the number of weeks.
Yeah. So actually, going back to the initial case, kind of left a few things out in terms of like the treatment, especially if this is a call that you get overnight. So I think I got this call around like 10:30 at night. So it's 10:30 at night. First thing, we kind of went through like my initial thoughts about how I would think about the x-rays, put it in the splint, get the CT. This isn't a patient that needs to go to the operating room emergently. It was a closed injury, and the patient was neurovascularly intact. However, if this is a call you're getting overnight and the patient isn't going to go to the OR until the next day or even the day after, one thing you certainly want to do is compartment checks overnight. So make sure the patient remains neurovascularly intact. You have the splint on, so through the ACE, you should be able to continue to assess the skin and palpate his calf compartments, and just to ensure that his compartments remain soft and compressible throughout the night. Typically, we do Q4 compartment checks, so every 4 hours or so. I saw this at 10:30, so 2:30 and then 6:30 a.m. Want to check in on the patient again, make sure that he remains comfortable, doesn't need further increased analgesic requirements. And, typically, you'll know right away if you should be concerned or not. You walk into the patient's room and patient's sleeping, compartments are probably fine. You should still check them, but probably doing all right. Make sure you check the pulse, compartments, if they're soft and compressible, as I mentioned. Also want to assess for pain with passive stretch of the EHL and FHL. So just slowly move the big toe up and down, see if that causes a dramatic increase in their pain or not. And then check for sensation and motor function distally in the toes. So that's one big portion of it. Unfortunately, sometimes if you're at a place where there like isn't an orthopedic service and you're seeing this patient in clinic, sometimes like a smaller community ED might send this patient out, and obviously you can't do compartment checks when a patient isn't home. But if you're at a place with if an orthopedist is seeing this, pretty much 99.9% of the time, this is a patient you're going to keep in the hospital with the intention of going to the operating room either the following day or the day after. Isn't really a patient that you want to ever send out from the emergency department, so that you can do your compartment checks. So as you mentioned, we kind of going back to what you were asking about. So you see this patient in clinic, let's say a couple weeks after, just so and really at that 2-week point, you're really just assessing for like doing a wound check. So just, hey, sutures out, sutures good to come out, yes or no, take the sutures out, and just seeing how the patient has been transitioning back into ambulation, how they're getting around, are they still using kind of assistive devices to get around, crutches, or have they been able to transition away from using them. Tibial shaft fractures take a long time to heal and feel as though they did not occur. So this is a patient you're going to be following for months, especially just to make sure they do go on to union. But you want to, but like six weeks out, kind of get a better sense of, hey, is there interval change in what the fracture fragments look like? Are they displaced, distracted, etc.? And as the months go out, you should kind of progress more towards bony union.
Yeah, that makes a lot of sense. Thank you. I guess another question, when it comes to like the initial injury or like the insult itself and you're looking at it, so if you heard the consult, you could obviously ask like, okay, is it open or anything like that. But if you did hear the consult and the image is pulled up and you're looking at it there, is there anything on imaging that you're specifically like trying to key in on or look for when it comes to complications or anything that is particularly egregious that maybe would be like, okay, this is a little more serious than XYZ? Or if you didn't hear the initial consult or anything like that?
Yeah. So if like just the nature of the fracture itself might clue you into the energy of the mechanism. So the fracture that we looked at was spiral. So you can see it was probably like a twisting mechanism. Might have been low energy, but it was definitely a twisting mechanism, as opposed to, let's say, looking at a transverse fracture of the tibial shaft. Hey, this was definitely a high energy mechanism in order to cause a transverse fracture of the tibial shaft. This is probably a patient who's otherwise injured elsewhere. Like if I see a transverse fracture of the tibia, of the tibial shaft, in my mind, I'm thinking of a polytrauma patient. Um, but that's not necessarily always true, but just due to the energy of the mechanism, you can look at the way the fracture is oriented, and that can kind of tell you, hey, what happened here, before you even get the full story.
Okay, that makes a lot of sense. Thank you. Definitely appreciate that. Now, when it comes to whether it is reading images or the situation itself, do you have any advice for everyone else who's listening, any of us who are like my shoes or medical students, and this comes up?
Yeah, so I think the biggest thing, I kind of talked about this a little bit earlier, but the biggest thing is to make sure you take a deep breath, give yourself some time, and know what you're going to say about, have like that kind of pattern, the rehearsed pattern of this is an AP and lateral of think about which bone it is. Think about the laterality. Oftentimes the laterality will be on the screen, and that will help you out in a skeletally mature or skeletally immature individual, demonstrating so like you use if you use that phrase or that sentence to kind of buy yourself some time to think about what it is you're looking at before you kind of just say, oh, this is a tibia fracture, for instance. Like you want to go through that kind of standardized way of thinking about the fracture.
Okay.
Or the x-rays rather.
When you say skeleton mature and immature, can you use just like ages for that, or is there something on imaging specifically that you're like, okay, this person is definitely can't talk today, skeletally mature?
That's a good question. Yeah, so you're on the x-rays, you're going to be looking at the physis. So I'm going to pull my imaging back up. Yeah, so even with this, the AP of the knee, so you're looking at the physis here. The physis, you can see a physeal scar here. You know that this physis is closed. So this would indicate a skeletally mature individual. And in a, let's say, 12-year-old, 11-year-old, you'll see an open physis typically. And there'll kind of be, you know, it would probably be better if I had a pediatric x-ray up here, but yeah, so you'll just be able to see an open physis. You won't see this kind of clean physeal scar where the patient looks like they're done growing, essentially.
Okay, yeah, no, that makes sense. That makes a lot of sense. Thank you. Definitely appreciate all of this and you taking the time. This has been beyond amazing. A huge step for me because, like I said, images are my friends, and I'm sure a lot of people listening to this and who will be watching this also share the same exact feeling or emotions. Something that's probably shared amongst all of us. So this is huge, and taking like that first step forward into trying to like figure out and get our bearings as to where we are. And of course, thank you so much for not only taking the time to do this, but not only taking the time to do this, but like for providing the images and giving us this talk, because this is going to go a long way towards everything we need to accomplish. But as far like aside from imaging itself, anything that you want to share or tell us, any words of wisdom of anything like that?
Certainly. I just wanted to kind of to chat about, you know, oftentimes in orthopedics, particularly as a medical student, there's often this sense of, you know, people talking about how hard it is to match into orthopedics, and it certainly is. And don't mean to downplay that, but there's often a spirit of discouragement towards medical students about going into orthopedics. But I just want to kind of offer encouragement to, students who are interested in orthopedics, and definitely say, if you're thinking about it, you should definitely attempt to pursue it, because, I think this is a wonderful field, and I want, for us to kind of move away from, discouraging people to pursue, the field that they have interest in for one reason or another, because, y'all can do this, y'all can get to orthopedics, y'all can thrive. This is a medical specialty just like every other medical specialty, in the sense that, you got to go through medical school, you got to apply, you got to, put your best foot forward. And, y'all are putting your best foot forward already. So definitely don't sell yourself short by not applying into orthopedics if you want to do it just because you think you can, because you can.
Yeah, those are amazing words. Thank you. Definitely appreciate it. I mean, even from like our own standpoint, I know going into third year, it's something we're told quite often, where it's like, maybe you shouldn't mention orthopedics. Like, oh, you're going like, your IM rotation is coming up. Yeah, don't mention that you want to go orthopedics or surgery. Like, the stereotype behind that is something that it takes a lot to get over. I know from my first 2 rotations, every time I was asked like, oh, what do you want to go into? Like, my answer was pretty much the same. It was just like, oh, I really like XYZ, and I think I want to do something like maybe a little more hands-on procedural, but I'm not really sure yet, even though in my mind I knew exactly like, I want to do this, this, and this. But everyone tells you, yeah, maybe don't say that. I definitely, yeah.
Yeah, I think I was kind of obnoxious during medical school. I can't lie. I walked in the first day, I was like, I want to do ortho. So I definitely understand, being on rotations and not wanting to say, hey, I want to go into ortho. Hey, but if it's your truth, then you got to own your truth sometimes. But there is definitely a balance. If you're working with a clerkship director who, is always making offhanded comments about ortho, maybe don't mention you want to go into it.
Yeah, it always rubbed me a little the wrong way whenever you were on a service and they consulted ortho, they paged ortho, and then the comments come out, and in my head I'm like, okay, I'm gonna stay quiet here.
Yeah.
It was also a little rough whenever you got asked to, I guess, page ortho, and then it's like, because at my time in Miami, I did shadow a lot, and I did go to the pit quite a lot. So it was always like one of those things where I would call, in my mind I would be like, please don't be someone I've spoken to or I know. If you recognize me, they're gonna have questions, and yeah. I don't know what I want to do. So I definitely feel that. And thank you, of course, for everything once again. I know for a fact that JR might contact you to do a more laid back version on the podcast itself, because definitely want to hear your story and how you got here. You probably took a different route when it comes to it. So thank you for everything that you've done for us here, and we definitely appreciate your support and continue giving here. And to everyone else, thank you all for watching. Stay tuned for our next episode, where we go again and try to figure out a different, we try to approach a different hyopathology through imaging. So until then, stay plugged in, and thank you all.